I want to thank the Italian Physiological Society for the opportunity to present this lecture as part of your series. I'm going to be talking about pain mechanisms, the fundamental biology, really where neuroscience is predicting the future of pain management. And I'll be covering some material that is new, some hopefully going to lead to new ways to deal with chronic pain. So thank you. Now, the traditional view about pain processing often begins with a discussion of Descartes, who actually wrote about pain. What Descartes said is that you burn the foot and information travels up. Of course, they didn't know about synapses and they didn't know about nerves, but it rings a bell in the brain and you get pain. It's a very simple telephone wire type mechanism. And somewhat sadly, this is not that different from what the textbooks mostly teach. Of course, it's more sophisticated. We have synapses and we have nerves. But basically, it says you have afferent fibers, nociceptors that respond to injury stimuli. They get activated, and they send information into the spinal cord, it goes up to the brain, and you get pain. It's very much a Cartesian-type view. Of course, if this were as the way it really worked, all you would have to do is cut, which neurosurgeons have tried, and you would solve the pain problem. But it doesn't work. It's much more complicated. So let's begin with a primer on acute pain. Basically, let's take an arm, look at this individual's arm, and look at the afferent fibers. And what we see is there are three major types of fibers. The large myelinated fibers that conduct rapidly, they do not respond to painful stimuli. They respond to light touch, they respond to joint position, movement, they respond to vibration, but they do not respond to painful stimuli. Then we have the small myelinated fibers, and the small myelinated fibers, some of them do respond to painful stimuli and generate an acute sensation of pain. And then we have a large population of unmyelinated axons. The great majority, but not all of them, respond to painful stimuli, heat, mechanical, chemical stimulation. There is a small population we call these C low threshold mechanoreceptors, which actually respond to hairbrush, which is an interesting population under study these days. Now, when you burn the hand, what happens? Well, very simply, you burn the hand, you activate a nociceptor, an afferent fiber, which is unusual and has a dorsal root ganglion cell body outside the spinal cord. The information goes into the spinal cord, you get glutamate release, activates second-order interneurons and projection neurons, goes to the brain, and you get pain. It's very simple. Now, what's the most effective way to block pain? Well, of course, we all know that. It's local anesthetics. The dentist has known this for years. The dentist injects local anesthetic, lidocaine, into the jaw near the tooth, into gums, and it's very effective. The local anesthetic blocks transmission in the nociceptor, block transmitter release, and you block pain. Of course, the problem is local anesthetics, if they go systemically, can have cardiac effects, can produce seizures, and so it's only because you can get very localized injections that things work very well. Now, is there a better way to do this? Well, the answer is recent studies have identified multiple subtypes of voltage-gated sodium channels. Lidocaine blocks them all, and it turns out that the NAV 1.7 subtype, I'm hiding part of this, is highly enriched in nociceptors. Not exclusively, but highly enriched. What that means is if you could maybe come up with a local anesthetic that only hit the 1.7 subtype, it could be useful. So what's the evidence that that's the case? Well, individuals with a gain of function of the NAV 1.7 gene have a condition called erythromelalgia. It's a terrible condition. Gain of function 1.7, excruciating burning pain, hands and feet, a lot of redness due to vasodilatation. So clearly this gene is important for pain processing. And most importantly, in a loss of function mutation, there's a congenital insensitivity to pain. These individuals never experience pain. It's a terrible condition because acute pain does in fact provide the signal that you have an injury and you need to do something about it. So it's necessary for acute pain but obviously the idea is to then regulate it in a chronic pain state, hopefully dose dependently, so you can still experience acute pain. But pharmaceutical companies are going after this here. They haven't succeeded yet. It's a difficult target, but hopefully it's on the horizon. The other thing about the nociceptor that's very different from what's usually taught is that it's heterogeneous, molecularly heterogeneous. I've just illustrated one as if there's 4 different nociceptors, and we know that different types of nociceptors express different channels, different molecules that may be targeted. For example, TRPV1. TRPV1 is the channel that is acted upon by capsaicin, the active ingredient or the pain-provoking ingredient in hot peppers. David Julius, a colleague of mine, recently won the Nobel Prize for discovering TRPV1. It is also, most interestingly, the heat channel, the painful heat channel. Its threshold for activation is around 45 degrees centigrade, which is about the temperature that most people will say the heat is starting to hurt. TRPA1 is another channel described by this group, and it responds to wasabi and other irritants. There are acid-sensing ion channels. TRPV1 is regulated by acid, and others that only respond when pH drops. Why is that important? Because in the setting of inflammation, pH often drops, and so perhaps that is a good channel to target. Piezo. Piezo 1 and 2 are mechanical transducers discovered by Artem Patapoutian, who shared the Nobel Prize recently with David Julius. Now, why do I think that mechanical sensors are important? Because I believe that musculoskeletal pain is among probably the most common type of chronic pain experienced by people. It hurts when you move. It hurts when you use your fingers. You have post-op pain. It hurts to get out of bed. And so finding mechanical sensors that are obviously contributing to the pain experience produced by movement, muscle, contraction, etc., joint movement, etc., is going to make a difference. Another interesting one is TRPM8. TRPM8 is a cold sensor and also happens to be responsive to menthol. Highly selective, so clearly this heterogeneity opens up possibilities. In fact, can we think of ways in which these could make a difference in a clinical setting? Well, one good example is chemotherapy-induced neuropathic pain. I'll talk about neuropathic pain later in the lecture. So particularly a drug called oxaliplatinum, which is used to kill tumor cells, often produces a terrible neuropathy to the point that individuals become so cold hypersensitive that they'll actually give up on the chemotherapy. So they're cold hypersensitive. Is there any way to treat that? Well, possibly a TRPM8 antagonist, which we know from preclinical animal studies. When an animal doesn't have a TRPM8 because you've knocked it out, the animal is cold insensitive. So this is the kind of approaches that are worth considering. So let's now take the information to the brain. There are other things to talk about in the cord and afferents, but let's take the information to the brain. Ascending pathways. Now, the traditional view, again, what's usually taught to medical students and other nursing students, etc., is the following. There are 2 major types of ascending pathways. One, the dorsal column medial lemniscal system, which gets input from A beta, large diameter, non-pain fibers, carry information all the way up to the dorsal column nuclei. The axons cross, go to the thalamus, and then onto primary somatosensory cortex. Now, the other pathway is what people call the pain pathway, not a good term, since pain's a percept of the brain, but nevertheless, A deltas and C's send information into the spinal cord, the synapse with axons that travel all the way up to the thalamus, part of the spinal thalamic tract, and then goes on to primary somatosensory cortex. These are the 2 pain and non-pain pathways, if you will. And the major features of the pain experience are what are important. There's a sensory discriminative feature. It's not just that pain is one element that generates a percept. The sensory discriminative feature says, well, where is the pain? Where is it located? What its modality? Is it heat? Is it mechanical? Is it chemical? How intense is it? Is it mild pain? Is it very intense pain? And we know from imaging studies that the sensory discriminative component of the experience is coded in the somatosensory S1 cortex. This can be seen readily. Apply a heat stimulus to an individual and do imaging studies, and somatosensory cortex S1 is lit up. Now, it turns out also S2 in the temporal lobe is also lit up, but most of the focus tends to be on S1. But of course, what makes pain special is not where it's localized, but that it induces an emotional or an affective, motivational experience. It hurts, and that's what ruins quality of life. How unpleasant is it? That's what really makes pain so special and also difficult. And it turns out that the emotional experience, the affective experience, is processed in different parts of the brain. In the insular and part of the temporal lobe, and in the anterior cingulate cortex, just dorsal to the corpus callosum. You can see this again in imaging studies, where here the anterior cingulate is lit up, in this case, as a function of the unpleasantness of the experience, and also bilaterally in the insular cortex. So this just illustrates the complexity of the experience, but let me leave you with one image that is rather penetrating. When I was editor-in-chief of Pain, the only thing good about it is I got to pick the covers, and this is an interesting cover generated by an artist who had post-stroke pain. When she painted this with a red background, she had no problems, no difficulty. But when she painted it with a blue background, she said the pain was excruciating in her painting arm. It was as if it was in the freezer of a refrigerator, and that's how unpleasant, burning, icy. It just illustrates the complexity of the experience, where even visual colors can actually influence the experience of pain. And remember, you can't see it. You cannot see the pain that a person experiences. We'll come back to that. So let's switch now to chronic pain. What about chronic pain? So we're talking about tissue injury pain, associated almost always with inflammation. Tissue injury, arthritis, fractures, cancer, so many ways that you can get tissue injury pain, illustrated in a patient with a severe arthritic condition. Now, this individual is not going to come into the office and say, you know what, doc, what I want you to do is to straighten out my fingers. No, what they tell you is that it hurts when I move my fingers. They have what are called mechanical allodynia, mechanical hypersensitivity. When they want to tie their shoelaces, it's excruciatingly painful. That's the big problem. So let's have a primer on chronic tissue injury-induced inflammatory pain. Relatively straightforward. So again, here's our three different types of afferent fibers. And now we're going to focus on what happens to the unmyelinated afferents, the majority of which under normal circumstance only respond to pain-provoking stimuli, 45 degrees heat, capsaicin, etc. You now burn the hand, and of course, the nociceptors will respond, and they will provoke pain. But when there's tissue injury, now those nociceptors can respond to normally innocuous stimuli, non-pain-provoking stimuli, but now they produce pain. Now non-painful stimuli hurt. It hurts when you move your fingers. It hurts when you take a warm bath. It hurts when you rub your hand, when normally that shouldn't be painful. So how does that come about? It comes about through a process called peripheral sensitization. So we have tissue injury. Tissue injury leads to a steroid-sensitive formation of arachidonic acid, lipid mediators. Now, steroids, of course, are used to treat these conditions, but again, if they go systemically, that could be real problems, and you can't take them for long periods of time. But for the purposes of this lecture, we're interested in the fact that the arachidonic acid is acted upon by the cyclooxygenase, or COX enzyme, leading to a cascade of enormous numbers of molecules. Just want to talk about one for this purpose, prostaglandin PGE2. Now, when PGE2 is released in an injury setting, say in the hand or the knee or the back or the neck, it binds, the PGE2 actually binds to prostaglandin receptors right on the nociceptors. And when it does that, it sensitizes the nociceptor so that threshold is reduced for activation. Now, the, quote, pain threshold is reduced, and you can activate that nociceptor with an innocuous stimulus, like light touch, or maybe a TRPV1 afferent might now respond to 40 degrees instead of 45 degrees. You have hypersensitivity, and you produce mechanical allodynia, the major clinical pain problem. Now, this will also be the case whether it's the hand or the knee or the neck. Same process. How do you treat this? Of course, you treat it with aspirin, ibuprofen, naproxen. These are all NSAIDs, non-steroidal anti-inflammatory drugs. They block the cyclooxygenase enzyme, and in the process, what they do is they normalize the pain threshold, and everything's fine. So what's the issue? Why can't we just give large doses of NSAIDs and solve this tissue injury hypersensitivity problem? So the real problem is that when you give the drug systemically, no matter what drug, particularly ibuprofen, it doesn't know where to go, and you're going to get side effects. Ideally, you want to target the area where there's inflammation and injury, but in fact, when you pop a pill, that just doesn't happen, and side effects are inevitably going to happen. So let's continue and talk a little bit about neuropathic pain, the other major chronic pain condition. And here's an illustration of a woman with postherpetic neuralgia, the first division, the trigeminal nerve. There's been nerve damage from the herpes zoster virus, and she has, initially it presents as shingles, which is very painful, can last about 2 months, and it recovers in most individuals, 80%, they're put on antivirals. But in about 20% of these individuals, there's been enough nerve damage that they're left with incredible burning, ongoing burning pain, and usually terrible hypersensitivity. Even light touch or wind blowing on the skin can be excruciatingly painful. That's due to nerve damage, very different from the tissue injury models. This is another cover, one of the most dramatic. It was done by a patient with complex regional pain syndrome who happened to be a sculptor, and he's trying to illustrate what it is he experiences all the time. And of course, nobody can see it, but it's like scalpel blades dug into his foot. Very hypersensitive, burning pain, etc. This is the neuropathic pain condition, usually due to damage to peripheral nerves, but can also occur in a so-called central pain cases after spinal cord injury, post-stroke, and in disseminated sclerosis or multiple sclerosis. So what are the contributors to the development of neuropathic pain? Unquestionably, the major contributor is a sensitization, NMDA receptor-mediated central sensitization, different from the peripheral sensitization that I described earlier. In this case, when you have nerve damage, you get a massive release of glutamate from the afferents. That produces overactivity and molecular, genetic, even circuit connection changes in the central nervous system that produce this sensitized state such that there is now ongoing burning pain, usually burning pain, and hypersensitivity through normal afferents. So light touch now hurts because it's now engaging an altered central nervous system. How do you treat this? Well, it's extremely difficult to treat. One possibility is to use ketamine, an NMDA receptor antagonist. It is now the drug of choice for acute depression, at least in the United States. I don't know about Europe. And it is effective in some individuals with neuropathic pain. But it has, again, a big problematic side effect profile. Interestingly, I should point out that afferent is not only sending information into the central nervous system when there is damage, but as you can see, I've noted that this afferent, in addition to including glutamate, the amino acid excitatory neurotransmitter, has a variety of neuropeptides, notably CGRP, calcitonin gene-related peptide, and substance P, which are not only released centrally, but also released peripherally, where they act on blood vessels and tissue, and they produce neurogenic inflammation, which is an important concept, and what we talk about calor, rubor, dolor, tumor, the 4 cardinal features of inflammation: heat, redness, pain, and swelling. And there's a clinical relevance to this, a very important clinical relevance, namely in migraine pathophysiology. Excuse me. So individuals with migraine, and it's very sexually dimorphic, 17% of women, 6% of men. And so what we now know, one of the major drivers of migraine is vasodilatation of dural blood vessels by the release, excuse me, of CGRP from the peripheral afferents of the trigeminal nerve. And the idea then is to use antibodies to CGRP to swallow up, scavenge the CGRP, and they are proving effective in some patients with migraine, and interestingly are even having some prophylactic effect, which is very useful in preventing the number of migraines. Now, another major contributor to neuropathic pain is to think of mechanism, and I like to think of neuropathic pain in many ways as a seizure-like condition. In epilepsy, what we know is what's happening in the cerebral cortex. There's a loss of inhibitory controls, there's hyperexcitability, and its manifestation is seizure. Well, when it happens in spinal cord, in the pain circuitry, there's a loss of inhibition, and now the manifestation is neuropathic pain and hyperexcitability or engagement by low threshold inputs that can cause pain. Again, if you look at the large diameter afferents, I pointed out that they do not respond to painful stimuli. However, pain is not just a function of the nociceptors. They're not just a function of the nociceptors because normally large diameter fibers inhibit the transmission of pain messages at the spinal cord. And they do it by engaging. Here's an A beta large diameter afferent, normally responds to light touch, joint position, vibration. It not only provides that information to the brain, but it also engages inhibitory neurons in the spinal cord, which regulate the output of the pain transmission circuitry. And that's how they come into play. And of course, we know that one of the standard ways that individuals treat when you have a burn, you often shake your hand, or you might rub it, or you vibrate it, or get a TENS unit, transcutaneous electrical nerve stimulation unit. When you use that, you're engaging large fibers, you're trying to bring in inhibition. And so you need to keep this in mind. If you lose the large diameter fibers, then pain can get worse. And there are many conditions, maybe even in diabetic neuropathy, where there's an anoxic effect on large diameter fibers, and you suddenly have an overactive small fiber system, and you have ongoing pain and hypersensitivity. If you lose the A betas, pain can get worse. Now, I made a film of this here, but I don't have time to show it. But this was a former student in my laboratory who's now on the faculty at UCSF. And I put a blood pressure cuff on her arm a long time ago. And remember, in her arm, she has the A deltas and C fibers, which respond to painful stimuli, and the information goes to the brain. She also has large diameter, so non-pain. I always put it in quotations. And what the cuff does is it blocks the large fibers. And I can tell you that what happens is the small fibers conduct totally normally. You can stimulate them with cold or pinprick or pinch, but the perception is completely altered. The arm is paralyzed, she can't feel touch, she can't feel vibration, but pinprick, cold, or pinch only produces burning. It really replicates the neuropathic pain condition. If you see a patient come in and reports that they have burning in their hand and they didn't burn themselves, chances are that they actually have nerve damage. Now, also in a kind of quasi-epileptic foci is a loss of GABAergic interneurons, of course, in this case not in the cortex, but actually in the spinal cord. And when you have damage to a peripheral nerve, you can in fact lose, not necessarily actually lose the interneurons themselves, GABAergic neurons or sometimes glycinergic interneurons, but you lose their function. And of course, now any input coming in is going to be enhanced, increased spontaneous activity, hypersensitivity, central sensitization, and more pain. How do you treat this? Well, you treat it as if you're treating epilepsy, and in fact, you use anticonvulsants. Gabapentinoids are the first-line therapy for treating these conditions. Makes perfectly good sense. Again, the big problem is that it is only effective in maybe 30 to 50% of patients and only reduces pain maybe 30 to 50% of the amount. It's not that good, partly because you can't give enough because of side effect profiles, almost certainly. Now, hopefully that will get rid of the pain in enough patients. But there's a different approach that we have proposed and have studied, and it really has a different premise. We tend to think of pain as a symptom of somebody else's condition. You have arthritis, you got inflammation, pain is a symptom. Well, seizures are not a symptom of epilepsy. Seizures are the manifestation of loss of inhibitory control in the cortex. So I would like to suggest that it's good to think, maybe we should think about neuropathic pain not as a symptom, but as its own disease. That neuropathic pain is itself a disease of the nervous system. And a really unusual disease, it's a disease you can't see. Here's an individual with phantom limb pain. There's no limb, and yet they have chronic neuropathic pain, a phantom, and the phantom hurts. The individual is not crazy. Everyone has a phantom, and about 20% of these people have uncontrolled pain. This is a disease of the central nervous system and the peripheral nervous system whose manifestation is pain. It's not a symptom of loss of the limb. And I think it's an important way to think of it. So then the question is, here's a different way to approach therapy, perhaps. Instead of trying to push down or eliminate the symptom, maybe you can repair the damage, rebuild the inhibitory circuitry. It's an approach we've decided to try, and we've been doing this. And our approach is to use embryonic precursors of GABAergic neurons, initially from the embryonic mouse cortex, that we then transplant into the spinal cord where they actually grow. One of the messages here is that the adult central nervous system, and that includes the spinal cord, of course, is incredibly plastic. It will accept these transplants, it'll integrate with them, form synapses with them, and we can treat pain. And in fact, here's an example where we injected, they're green fluorescent, the cells, when we take them out of the embryonic brain, inject them into the dorsal horn. This is at 1 day. These are GABAergic progenitors. After 1 month, they start to spread around. They don't go to the other side of the cord. They don't go to the cortex. They stay within the dorsal horn. This is what one cell can look like. It grows, it's got beautiful processes, it forms synapses with the host forms synapses with these transplants. And to date, in different mouse models, we've treated models of peripheral injury-induced neuropathic pain, chemotherapy-induced neuropathic pain with paclitaxel, or an oral facial neuropathic pain model after partial nerve injury of the infraorbital nerve, and even a model of chronic itch, an atopic dermatitis model, which we can regulate by controlling output of the spinal cord. So it's an exciting opportunity, and I know there's some effort to approach this clinically. Another significant contributor is a loss of descending inhibitory controls. So anything that's going to result in loss of control of the dorsal horn is going to lead to hyperexcitability, spontaneous pain, and inputs that are normally not painful are going to engage abnormal circuits and cause more pain. And under normal circumstances, there is descending control, serotonergic and noradrenergic controls that regulate the output. When you have nerve damage, you can lose a lot of that control. And it makes sense that what's the second-line therapy for treating neuropathic pain? Well, when the pain increases in this condition, it is serotonin, norepinephrine reuptake inhibitors. Duloxetine is one example. So the gabapentinoids are the first approach, treat a seizure-like condition. Serotonin, norepinephrine reuptake inhibitors, the second-line approach. Interestingly, the SSRIs, like fluoxetine, they're very good for depression, of course, but by themselves, they're not very effective in neuropathic pain cases. It's the combination that seems to be particularly effective. And again, hopefully the pain will be reduced. So let's switch now to something a little bit more traditional, perhaps, deep brain stimulation. It's not traditional at all. but I introduce it because I find it a very good way to introduce opioids and opiates. So many, many years ago, I actually worked on this in preclinical models, and it is still done. Of course, it's very common in the Parkinson's and other motor disorder conditions where you either lesion or try to stimulate parts of the brain. It has been also used for chronic pain conditions. Here's just an example where you implant the electrode. In this case, as you'll see, it's targeting the midbrain. The wire goes down and the patient can actually control and stimulate themselves. And we understand quite a bit about the mechanism for deep brain stimulation for pain control. The electrodes are targeted towards the periaqueductal gray in the midbrain, around the aqueduct. This is a rather large aqueduct. When you stimulate the periaqueductal gray, you actually turn on a powerful descending control system that shuts off activity at the cord. But what's quite striking, and it's been shown in animals and even in humans, that the pain-relieving effect of brain stimulation in the periaqueductal gray is actually sensitive to the opiate antagonist naloxone, which is pretty remarkable finding, discovered in the 1970s. Now, so let's very briefly discuss, well, what's the significance of that naloxone reversibility? Well, we all know about opioid receptors. These are G-protein linked receptors that are found distributed throughout the brain, and they are acted upon by the endogenous opiates, the endorphins. And there are at least three classes. The enkephalins, dynorphin, beta-endorphin, are peptides synthesized on three different genes. They bind the opiate receptor, and they increase K conductance, so they hyperpolarize cells, and in some cases they actually decrease a calcium conductance, and so you get less transmitter release. By and large, they're inhibitory. And their effect can be blocked by naloxone, because naloxone binds the receptor and prevents binding of the endogenous opioids. Well, if that's the mechanism with deep brain stimulation, it makes sense to think, therefore, that periaqueductal gray stimulation must function by releasing local endorphins that then turn on the descending control system, and naloxone is the key. Now, this isn't used that much anymore for pain, but I introduce it because I find it a helpful way to introduce what we believe are mechanisms through which opioids exert their pain-relieving effects. So let's talk about morphine and other opioids, where opioids are a more generic group that includes the exogenous drugs like morphine and the endogenous peptides. So here's our model before. Endorphins bind opioid receptors, and the endorphins are the endogenous ligands in the brain that bind the opioid receptor. Well, morphine and other opioids or opiates like codeine, oxycodone, etc., bind the opioid receptor, and they do the same thing. They inhibit the cells that express the opioid receptor. So in other words, it makes sense that when you inject morphine systemically to go everywhere throughout the central nervous system and even in the periphery, it can bind opioid receptors in the periaqueductal gray, basically bypassing or mimicking what the endorphins would normally do. That would turn on the descending system, shut off transmission at the level of the cord, and block pain. Perfectly good sense, and we believe to a great extent that is how systemic morphine exerts its pain-relieving effects in individuals. So what's the problem? Well, the problem, as I said before, is that when you give systemic drugs, like morphine, they don't know where to go, and they will go everywhere, and they will find other opioid receptors, and you will get side effects. And most of these side effects will be adverse, not good. The worst one, of course, is respiratory depression. Many people are dying from overdoses of opiates. Not only prescription opiates, but certainly opioids, heroin, fentanyl coming in illegally, etc. But that's how it happened. It shuts off the respiratory drive centers, which have opioid receptors, and you end up dying. Many people take heroin because they want a high, because opioid receptors are in the reward system, there's dopamine release, and that's clearly one of the major adverse side effects of a systemic opioid. And interestingly, gut constipation. There are opioid receptors in the gut. And when you take systemic opiates, and particularly, say, an individual who's taking lots of opiates for cancer pain, it will shut off their gut, and they will be so constipated that they may say, look, I can't take the chemotherapy anymore. This is too unpleasant. This is a real serious problem. Now, interestingly, how do you treat the gut constipation? Well, it's the opposite of, you might use a naloxone version that can't get into the brain, but what I always ask the medical students is, have you ever experienced diarrhea? And it's interesting, they hardly ever put their hand up. Of course, they're shy. But I try to explain that, I ask the question, how do you treat the diarrhea? And they all know the answer, of course. They say, well, Imodium. And I say, do you know what Imodium is? Imodium turns out to be an opiate. It is an opiate that binds the gut, opioid receptors, but it is kept out of the brain by transporters. So you can't get any of the effects from the central nervous system. It is a brilliant drug. It doesn't know where to go, but it can't go anywhere except stay in the periphery, and it's effective. That really highlights the interesting approaches to developing drugs and targeting them. Targeting is another approach that is used clinically all the time. There are opioid receptors in the spinal cord, and so another approach is to epidural morphine. In this case, the morphine is injected epidurally. It penetrates the spinal cord, binds opioid receptors in the spinal cord, and shuts off transmission. This is used for just labor pain. It is used in pumps in individuals who have cancer pain and they need long-term control. And the hope is that the morphine, by focusing it at the spinal cord, and it's remarkably selective for just blocking pain, doesn't produce paralysis, is that if it doesn't go to the brain, you won't get the side effects typically associated with systemic morphine. Let's talk about a few other things. Placebo, acupuncture. Now remember, pain is a percept. It's a complex perception of the brain. Colored, it has an emotional component, it has a sensory discriminative component. If indeed there's a cerebral component to it, and it's influenced by psychology, it makes good sense that placebos, psychological influences, should be able to make a difference. And of course they do. And in fact, Fabrizio Benedetti has done some of the most beautiful work demonstrating the mechanisms of placebo analgesia, earlier reported many years ago by Howard Fields and John Levine. It turns out that placebo analgesia can be blocked by naloxone. And people used to say, well, that's ridiculous, that's impossible. Well, no, the mind's not separated from the brain. What it suggests is that psychological influences can engage the endorphin system and engage the descending control system, pain-relieving effects that are endorphin-mediated. It makes perfectly good sense, and Fabrizio has done some elegant work on this system. It also emphasizes the point that when you're dealing with a patient and you give them a new drug, it's important to say, I'm excited about this drug. I think it's going to make a big difference. We've tried everything. This is something new. I'm very excited about it. Why? Because you're adding a placebo component. There's actually something called the nocebo effect, where if you give the wrong information, you sort of say, well, I really don't think this is going to work, but what the heck, try it anyway, because I don't know what else to do. You could actually make their pain worse, and you could counteract the effect of a drug by giving the wrong message, because you are affecting the cognitive element in the pain experience. Now, this always comes up in my lectures. What about acupuncture? I personally happen to believe that acupuncture is an exotic placebo. That doesn't mean it doesn't work. Placebos work. They can be very effective, and but in the case of acupuncture, in my reading of the literature, is several things. One, there have been many, many, many studies done. It doesn't matter where you put the needles. If it works, it will work. The needles targeting doesn't seem to make a difference. And most of the common places done certainly is Hoku, median nerve, Susan Lee, superficial perineal nerve. Yes, I'm sure there are a couple of papers that show that it's better than placebo in a controlled, but in many other studies it's equivalent to placebo. So that's my personal opinion. The other thing is that to my knowledge, it's almost never used for pain in children under 10. And why is that? Well, children under 10 are not good placebo responders. When the big needle comes along, that's bad news. And so this is my personal feeling. Stress and distraction and other psychological mechanisms. I show this image. This is former President Reagan, who obviously died many years ago, but this picture was taken very soon after he was shot. And his communications director was shot lying on the ground. He saw what was happening. He didn't realize he was shot until a little time after. The situation was such that he didn't experience the pain. Stress, anxiety, etc. can influence because pain is a percept. It's a product of the brain. It's not inherent in the stimulus. So clearly this comes into play. Novel pharmacotherapies, I don't have much to say about this here. The data is still not clear, but cannabinoids, there's a lot of people argue that's the best thing, works for everything. For pain, the fact is that there's very little good data demonstrating that it is effective for chronic pain. That doesn't mean it doesn't work. What I'm saying is we need more studies to get better studies to see whether cannabinoids are effective. CBD, everyone loves it. It is certainly good for certain childhood epilepsies, but the data on, as far as I know, the data for managing pain, it doesn't exist yet. The latest thing on the horizon, hallucinogen, psilocybin, is now talked about, and we shall see. We shall see. The last thing I want to mention is hypnosis. Now, hypnotic analgesia is underutilized, I believe. If pain is a product of the brain, then it makes sense that something like hypnosis could be used to change the brain percept, the way the brain reads or processes the information. And there's some very interesting studies suggesting that's the case. From my colleague, Catherine Bushnell in Washington at the NIH, they did a study quite a few years ago where they provided a painful stimulus to the subject and imaged their brain. And it was pretty painful, and as expected, it lit up the somatosensory cortex, S1, sensory discriminative region of the cortex, and the anterior cingulate gyrus. No surprise. But then they hypnotized the subject so that they didn't experience the unpleasantness. They said, oh, no, you will experience something mild, it's fine, but it doesn't hurt. And when they imaged these individuals, not much change, if at all, in the somatosensory cortex, but a big decrease in the activity of the anterior cingulate. In other words, there was a selective down-regulation of the emotional tone associated with this painful condition. Interestingly, hypnotic analgesia is not reversed by naloxone. So it's not an endorphin-mediated mechanism, but it illustrates the complexity of the pain experience. It also illustrates there's no one pain area of the brain. The experience of pain involves many areas of the brain, a gestaltive activity that generates the sensory discriminative, the emotional, and of course the cognitive elements that are associated with the context of the experience. And that's the message I want to tell you. To conclude, I mentioned that I write poems for my lecture, so I'm going to read you a poem that I wrote a few years ago that tries to summarize. The bane of pain is plainly in the brain. That, as some of you may know, is stolen or adapted from My Fair Lady. Now, textbooks teach that a rather simple circuit is all that you need to produce pain. Peripheral nociceptors to dorsal horn projection neurons, and then to the brain. But where in the cortex this happens, we have yet to explain. You don't just add an emotional component and poof, you have pain. It is indeed much more complicated. There are myriad molecular mechanisms. Let me name just a few. There's peripheral sensitization, arachidonic acid, COX enzymes, and NGF2. Yes, the nociceptor transmitter is glutamate, but it co-expresses CGRP, providing hopefully continuous research funding for a neuroscientist like me. Marx had it wrong. It's the endorphins that are in fact the true opiates of the masses, so let's develop a better opioid, whether it's in the mu delta or kappa opioid receptor classes. What a pity that the discovery process is at times as slow as molasses. Amazingly, we still do not know how good an analgesic drug grass is. We must conclude that pure pathways do not access the brain, which is undoubtedly why anterolateral chordotomy for pain's on the wane. But since analgesic drug action and circuit analyses exploit neurochemistry, electrical stimulation, and perhaps transplants in the treatment of pain. For there are few in this audience who could readily afford to relinquish the functions performed by the cord. Sure, the brain is important, but the spinal cord central. So come, blow your horns, be they dorsal or ventral, and let us end by rephrasing the words of the Lord, honor thy mother, don't cut the cord. Mille grazie.